Okay. Well, good morning. I'd like to welcome you all to the January Prescription Drug Affordability Board. And I'd like to make an announcement before we get started. And many of you may be aware of this already, but effective noon today, I will take over the position of the acting director for the Healthcare Authority. And I will stress the word acting. It's a great short term as they continue to recruit Sue Birch's replacement. So with that, I'm not able to remain on this board. So I have to officially resign as of noon today. I do hope that I'll be able to get back on the board when that appointment is over. Again, I do not. This is not a position that I am going to again do for long period of time. It's going to be probably 3 to 6 months is what we anticipate. So anyway, I am going to stick around for a little while this morning, and I will go ahead and turn the meeting over to Mike, or if anybody has any questions or anything.
Good luck.
Thank you. Thank you.
Great, yeah, and we're very excited for you, and that's fantastic news. And yeah, if once you're done with that, you're able to hop on back board. We'll definitely be glad to see you return, and hopefully just kind of keep on going.
Ease back in.
Yep, perfect.
Thanks.
Well, great. So that was kind of actually one of the first things on my thing. I wasn't sure if you were going to stay around here for the meeting this morning. So that's great. Next thing, just in terms of director's report, just to make sure everyone knows the dashboard that we sent out to the advisory group and the board members for the list of drug reviews, or not the drug reviews, but the list of drugs for selection with the data is on the PDAB webpage. So if anyone needs to see that or wants to look at it in the general public, they have access to it and are more than welcome to. And then also one of the things that we're doing, so we're currently over the next couple of meetings going to be working on looking at this dashboard for drug selection, but we're also trying to look ahead for the drug review. Again, we're kind of building this plane as we're flying it. And so one of the things that we've been working on just on the back end are some of our data submission forms for our industry partners. So as we are going to need to collect data, we have some of that from our internal sources, which we've been using to help build the dashboard. But there's also pieces that we'll need to be collecting from the industry partners themselves of whatever drugs that we select. So we have some data submission forms, and one of the things we were wanting to do, just kind of give a heads up, is to set up a meeting where we can have an opportunity to get feedback from industry partners on those forms. Just again, some of that feedback that we've received in the past from our industry partners has been really helpful in terms of helping us set up, how we're doing these drug selection here thus far. So just kind of an FYI, that's something that's coming down the pike, and Daria will probably be reaching out for some help in terms of doing steps with that. And then also I know we had some comments during our advisory group meeting, which happened December 10th, just in terms about, our process for selecting the drugs and, making sure that was a solid process, and, we weren't doing anything that would be considered arbitrary. So Michael was going to give us a little chat in terms of kind of in legal terms, what that all means.
Yeah. And so again, I wasn't present, so I not like opining on sort of the reasonableness of the process, but more of just sort of in legalese or legal speak. When I hear arbitrary and capricious, that's a judicial standard of review, generally confined to review of administrative agency action. And so I'm just going to go with arbitrary and capricious, defined as the result of willful and unreasoning disregard of the facts and circumstances. So when I sort of read cases, then I look at the Merriam-Webster's dictionary definition, they're pretty much like what you might, as like a layperson, think of as what is arbitrary, what is capricious. fits within that sort of legal definition. And it's a highly deferential standard of review, one where it won't really be set aside unless, like, the reviewing court says, they're just clear showing of error, there's room for two opinions, even if the reviewing court might disagree with the outcome, as long as there's sort of like a reason to process. And I'm just going to provide sort of some examples. And the first one is one that I would say is one of the most famous but seemingly unreasoned judicial actions or unreasoned government actions would be, I'll go back to thousands of years to the judgment of Solomon. So this was the settlement of, or the a child custody dispute, which King Solomon ordered that that a baby be cut in half. And so that seems, so King Solomon was not being despotic, he was being quite wise, because and I bring this up because a lot of times it's not so much about the outcome, but more about the reason for getting there. So here we have a very difficult situation where King Solomon didn't know who the true parent was or who the true mother was. And so he came up with a pretty ingenious way to sort of ferret that out by sort of ordering that the baby be cut in half, that the true mother would reveal herself by rejecting the judgment, and the false mother by accepting it. And again, so that's an example of something where it seems, again, like that's not necessarily a reasoned outcome, but once we sort of understand the logic behind it, we're like, as we know, King Solomon was very wise. And so okay, then other stuff. I was going to say, like, legend has it that Julius Caesar would settle legal disputes by a coin toss, and so nowadays we think about it, we're like, well, that's an okay way to decide who will kick off during the Super Bowl, but we don't necessarily want all government action. But I realize that in election disputes, not election disputes, in election ties, a lot of states have basically games of chance as the way to decide who the winner is, whether it's a coin toss, drawing a card from the deck. In this state, it's drawing lots, which I'm not exactly sure what that is, but it's some sort of a game of chance. I don't know if it's pulling straws. Now that's by statute. And so statutes are a little bit, the legislature has a little more leeway.
Never arbitrary and capricious.
It's not going to be arbitrary or capricious. And so the advisory committee can't flip coins to decide things, but just sort of bringing up that, like, there games of chance are not ways to for a judicial decision, but there are narrow circumstances where it does actually turn out to be okay. And then I was just going to say that the government does have to sort of draw lines. And from my understanding, sorry, I'm going along. A long time here was that there was something about, there's a certain number of drugs that can be reviewed. And so you have to sort of narrow down a list somehow. And again, I'm going with the statute here, but the retirement age used for Social Security is 65. Like, why not 64? Or I think it's going to go up to 67, 7. And so there has to be some line drawing. And so, sort of the cynic in me always thought it was, well, the retirement age in 1935 or whenever it was that they passed the Social Security Act initially was like, not the retirement age, sorry, the life expectancy for men was about 58, women were about 62. And so I was like, well, I figured no one would live that long to get the benefits. But I guess it was actually based upon other private and public pension systems had either 65 or 70 as the retirement age. And so they looked at sort of actuarial calculations. They thought people could pay a small tax and have a retirement based upon their the lifespan. So and then and so then when the Medicare and Medicaid programs was, they adopted the same 65. Again, that was just more administrative expediency because it was, they already had the infrastructure in place to find out who's eligible and who's not based on age. And yes, I guess what I'm going for is that a lot of it is about sort of the process and the reasoning, and it's not necessarily, I mean, the outcome has to sort of match the facts, but the outcome doesn't have to be like preordained. So it's not necessarily whether we agree with the outcome, but as long as there's sort of a reason for it. And well, any questions? If there were questions, I would provide more examples of, yes, it's tough to find examples of arbitrary and capricious. I'm not saying that they don't exist, but I was sort of reading the Federalist Society. I think when they said that since somewhere like 1982 or something, the Supreme Court has upheld 92% of cases that have, under the standard of review. So there are recent examples where I think with like the DACA deferred action, childhood arrivals, and so it wasn't like the repeal of it wasn't something that could be supported, but because there was no explanation for the repeal, it was found arbitrary and capricious. So that's something where and I think there were a few examples like that with the last couple of presidential administrations. That's on the federal side where they were sort of undoing the prior administration's work, but they didn't sort of go through the effort of providing an explanation, going through the process of actually doing the change. And so I think that's more top of mind. It's like, did the Supreme Court recently do? And it's like, well, those were examples that sort of almost like prove the rule. And so again, I don't want to like say, oh, you can do whatever you want.
I have a question.
Somebody's having trouble hearing.
Oh,
You gotta probably speak up.
Yeah,
oh, I'm sorry.
that's fine. Yeah, just speak up
Okay.
into the microphone a little.
Okay, yeah, so with so where agency action is found arbitrary and capricious, it tends to be that there are certain factors which need to be considered that haven't been considered. And so an example I have is where the Growth Management Hearing Board was applied a test for substantial compliance. I think there was like a late application and they failed to consider prejudice when they determined that the sort of substantial compliance with the filing requirement had not been met. It was something where it was really just like I think they were supposed to like serve the board and the city, but they did it in the opposite order. And it determined that procedural filing requirement had been met. They failed to consider their own rule, which said, if there's not prejudice, which there wasn't in that situation, deem it substantially complied with. So that's where they failed to consider a factor. Other times, maybe the considering factors that should be considered, or situations where just the decision flies in the face of the evidence for them. So I have one where the Department of well, it was rulemaking for I don't even know how to pronounce this, chemical cholinesterase testing, and they opted not to do rulemaking because they had limited resources and their priority setting was to do other things, but the evidence record showed they actually had been studying this and that they'd had sort of informal guidance, and so that their explanation for denying an application for rulemaking was deemed arbitrary and capricious because it just sort of flew in the face of the evidence before then. And so
thank you, Michael. This has been really thorough, and really helpful. I mean, that's a term that gets thrown around a lot, so it's
Yeah.
good to have
A lot of labor law.
Yeah, absolutely. And so it's good to have kind of a refresher course in some way, so thank you.
All right.
I don't know, is there any questions from anyone? Anyone online? Nothing, okay.
So I think the general gist is that, making sure, 'cause we have methodologies that we've developed in terms of creating the drug list, in terms of, how we're prioritizing the drugs. We're not going against the legislation or our rules, and that we have a reasoned decision of how we're coming to these selections.
So a real process.
Yeah.
Yeah.
So apparently there's some difficulty with some folks hearing. They can hear part of it or nothing. So I don't know.
Hear us better now?
Yeah.
I can hear okay.
Can you hear okay? All right. So some,
Ronnie says yes.
okay.
We'll project.
Yeah.
Talk with our booming voices. Okay, great. So any other questions in terms of that? I think that for me helps clarify, I guess, making sure we stick to our methodologies, that we're following our processes, that we're creating reasoned decisions. And as long as Marianne isn't trying to divide any of the HCA staff in half, I think it should be good.
It should be good, but you never know.
Okay. Good.
Are we on to?
Yeah, so then I think that takes us on to voting on our drug selection policy. And we've taken a look at this during our last meeting, and this is basically just kind of how our weights and ranks work to create the drug dashboard, which we've been looking at. So yeah, unless there's any questions on that, I think we can move forward.
Need a motion?
You ready for the, okay, yeah, motion. You ready to-
I move that we accept the drug selection policy. We affirm, whatever.
And I second that. So all in favor?
Aye.
Board?
Aye.
Folks on the.
Aye.
Aye. Great,
Okay.
well, it's been moved and seconded and all votes in favor, so we have adopted that. So adopted with the fake gavel.
Awesome.
So at this point, I am going to head upstairs. And again, I look forward hopefully to join you all and.
Yeah, you can't get out of this.
So thank you. Have a
Thank
good
you.
meeting. Take care, guys.
All right, see you later.
And I just want to say that we still have quorum to
Still
have
a
it,
quorum,
and if I understand it correctly,
Your team-
Representative Cody is now.
Not Representative Cody anymore.
Oh, sorry. Eileen Cody is now the chair, was that right? You
Yes,
were-
I'm second, so I'm gonna be,
acting
yeah,
chair.
yes, unless anybody else wants to really jump in and take over. We'll stick with that. Yeah, all right, so now we move forward to the dashboard, reviewing the data on the dashboard. Is she on that? I can't tell.
Kelly, Jinping, you wanna walk us through that again? And I think this is the time, board members, if you have questions on functionality or features, this is a great place where they can probably answer anything you would like to know.
Yeah, sure, I can share. All right, so oops. If you're not sure where to find the dashboard, if you go to, sorry, this bar keeps popping up. If you go to the website, the link to the dashboard is under policy resources and then PDAB data dashboard. So this is what the dashboard looks like when you click on the link. So there's a bunch of tabs, so you can navigate through the tabs to view the different dashboards. But I'll go through each tab just to show you what's on it. So the first tab is the dashboard overview. So it gives an overview of how many drugs are in the dashboard, information about our data sources, as well as some limitations. So one of the things you'll notice in the dashboard are any prescription drugs with less than 10 people using the drug won't be on the dashboard. And then any other measures that use the number of people using the drug in the calculation will also be blank. So you can't back calculate how many people are using the drug. And I'll show you some examples of how that would look if they're missing. Next is the dashboard information tab. So this just gives you more details on what each dashboard or each tab up here, like what information they each contain. And then if you wanted to like see the information for a specific dashboard, you can also filter by that and just look at that rather than scrolling through the whole thing. There's also the data dictionary. So this gives you the definition and data sources for the different terms and calculations used in the dashboard. And then again, you can also search and filter by a specific data field if you want to go to it really quickly. And then getting to the data, this is an overview of the drugs that are eligible for affordability review. So we have 294 drugs, and then we have a graph here that breaks down the drugs that are eligible because of their cost of course of treatment by biologics and brands. And then here we have interactive graphs. So you can sort by like how many drugs you want to see. And then they're sorted by like top number of people using the drug product, and then top products by total paid amount. And then again, for this graph that shows the top drug products by number of people using the drugs, if there's less than 10 people using the drug, it won't show up. Next is a more detailed dashboard that goes into like a lot of different measures for each drug that's eligible for review. So if you go to select label name, you can search for whatever drug you're interested in by label name. And there's also NDC available. And then, so here you can see that this drug had more than 10 people using the drug, so everything is populated. But if, for example, there's a drug with less than 10 people using the drug, you'll notice that these three measures are missing. And then if the drug didn't have any claims data, then it'll just be missing for like all 8 of these boxes will be missing. We also have a dashboard that's showing the number of drugs on multiple lists and like which lists they are on. So for example, this first drug is on both the 15% increase or over and 50% increase or over list. And then it also shows whether they're specialty or not, which they all are not. And then finally, we get to the prioritized lists. So we have 2 lists, one list of top 25 specialty drugs and one list of top 25 non-specialty drugs. So here you can filter by specialty drugs or not, and then whatever you choose will show the top 25. And then there's also a lot of data here. So there's the weighted rank, which we use to select the top 25 for specialty and non-specialty. And then there's the data for the 6 selection measures that were used to actually make this list. So they're highlighted in gray. And then there's just more data measures to provide context. And these are also in the drug lookup tab. And you can also filter by label name if you want. So this is useful if you want to like compare like 2 drugs. So for example, you just want to see the data for 2 different drugs. You can just look at 2 at a time or 3 at a time or whatever you're interested in. And this also links to the last tab, which is some visualizations. So whatever you filter in this prioritized list or whatever you filter in this list, they're like connected to each other. Like their filters are connected to each other. So whatever you select here, it'll show up here and vice versa. So I'm just going to take off the filter for now. So this is like a visual representation of the data in the previous tab. And yeah, it just shows you the distribution of the different measures. And then I know this increase over 1 or 3 years looks kind of weird because there's only one data point, because only one of the drugs on either of the top 25 lists was on like the increased list, like all the other ones were on the course of treatment over $60,000 a year. So there's only like one data point here, but I still think it's useful because if you hover over it, you'll see like more detailed information. And then same for the other graphs. If you hover over them, you'll see like more detailed information. And yeah, that's all for the dashboard. And yeah, let us know if you have any questions or feedback or concerns.
I'd say it's quite a database. That's the that would be my reaction to all of it. Any comments or questions?
And this is public data, so anyone can come in and take a look at this.
Correct, yeah, it's on our website.
Is there any way, I know there's like, it's kind of broken up by NDC for the drugs themselves. There's no way to combine like, I don't know,
All of the
specific drugs.
doses?
Yeah, all the tablet sizes of some dose or anything like that.
You mean within the drug product lookup tool?
Did you hear that question?
So Kelly, so like, for example, putting all the Enbrels
Yeah.
together,
One dosage, yeah. Or like all the Affinitor tablets or something like that.
so Kelly, can they like select just to see what all all the Enbrels together on that 25 list?
Sorry, are you talking about this tab and like collapsing these together, or are you talking about collapsing the drugs in this tab?
I
Because
guess,
on that one you can filter, right? Go down to filter by label name. And then you can leave all of the drugs with this, like
okay.
drugs together, and then you can see them just lined up together.
Yeah, that'd be helpful, and then I could just add them.
Yeah, and so then, you can see, for example, what they would look like.
Yeah, I mean, I agree that so in this section, what you're showing now, that they would still be on separate rows though. So if you took, say, the Cabomedics 20, 40, and 60, it'd be a different row for each of those. It would be, I mean, I guess it would be helpful if especially in the drug product lookup tool, if you could consolidate by, say, generic name, because that way you could get the all of the data consolidated for all of those rather than having to switch between them and see what the figures are for each of the different formulations or dosages or whatever.
Yeah, because ultimately, if we put a overpayment limit on something, it would be it wouldn't just be for a single NDC, is that correct? It would be for products within all the Affinitor tablets or something like that.
Yeah, so that was one of the things that we were talking about doing is, we pick a drug, but then we would, group them together and then do the review on the group.
Yeah. So if we're trying to, compare all of these kind of somewhat equally, if you have a drug with many, many tablet sizes or dosage forms, you're sort of may not show up high on this list that we're looking at.
So Kelly, do you think, I guess the question is, can you do that? Or I guess the question for you guys is the way that she described that she could do it, does that work for you? So
Yeah, like for example, go Kelly.
So I think we might be talking about two things here. So I think one, like you're talking about whether we're going to whether we should have rolled up the drugs before we created this top 25 list. And I thought that we agreed that we would just go with creating this top 25 list, and then we would roll up the drugs by label name or whatever after we selected whatever drugs we're going to review. But now we're thinking maybe we should roll it up before we create this top 25 list. Is that the thinking?
No, I don't think that's what, that's
I
not what you're
think it's-
saying.
You just want the ability, for example, with all the Enbrels, so I went and selected it on my screen, the top 25. And with the 5 different,
Emeralds.
Enbrels. And so just being able to, like, for example, add the total, people using it, the total paid amount together, right?
Yeah, just to kind of like lump them all together. I mean, we've got a top 25. They all look like pretty good targets. But then we'll have to kind of think about, within these drugs.
That's what meets your question too, Doug?
I think so, yeah. Yeah, for instance, like 2 and 6 together would be potentially rolled up if we were going to do an affordability review on that. So I do think in that decision, and I remember that we talked about this before when we were defining the level of drug, our level that we would be making this list at. And I can't remember why we decided to do it at this level rather than rolling it up a little higher. Does anyone remember that conversation?
Well, I won't say my memory's great, but I think it was that we wanted to pull it all out this way and then, like, as you said, roll it up after we did the top ones.
So, Kelly, can you go and just select the Enbrels on that list?
I mean, the only way is you filter it by generic name of it. Because it doesn't link any other, NDC is totally different. Yeah.
So is there a way to, like, just export this to Excel so then we can sum basically the stuff?
No, this doesn't allow you to download the data. I think it's a restriction because it's like a public dashboard, or I'm not sure. But Greg, I think what you're saying is you would like to see what the data looks like if we rolled it up. Is that what you're saying?
Yeah, I mean, if the board has already decided that they want to pick the top 25 based on NDC, like that's fine. But I think for like my decision making of the top 25, I think at some point we should factor in the cumulative cost of all of these products, to the patients, to the health system, total number of patients on it, and sort of get a more global picture of that. Just because, again, it's just because I see a lot of kind of the same drugs with different dosage forms, even on the top 25 list, and then it makes me worry that we're not seeing a complete picture of each drug. That makes sense.
I agree, and it's not as simple as just summing them because for instance, with the average out-of-pocket cost, you're going to have to take to calculate that for all 5 of those rows. You have to use the number of users, then the total out-of-pocket cost, and then recalculate for the 5 of those rolled together.
Ronnie, you're on the advisory committee. I'm sure you guys talked about this.
Well, I know in the portal presentation to us, they discussed the fact that other states are aggregating or putting all of the drugs together of a particular brand in order to develop the cumulative price. I don't know if that impacts our choosing the drugs at this point. It certainly would impact what the staff does with evaluating or finalizing the review. I believe that we will aggregate all of the different formulations of the drug in coming up with a final analysis.
Yeah, and in the drug review, that will be all put together. So yeah, I think, maybe what we can do here, do we have any more questions specifically on the dashboard?
I have a couple other points, but they're not related to what we're talking about now.
Okay. Yeah, Laura says, can we filter by usage by
Diagnosis. No, I don't think I can.
No, I don't think
think
we
so.
can't. We did not
Yeah, I think we
Yeah,
talked about
that's
that, and it
oh,
was
go ahead.
we weren't because we weren't able to see indication, at the claim level, and so we weren't able to know what these drugs were being used for, right?
Yeah, and I think another point was just as we're developing this dashboard to add the indications to this at this point, technically was going to be a bit of a hurdle. And so we had an Excel sheet that we sent out that did have the indications next to it, but we just didn't incorporate it into the dashboard.
I also wanted to add that if you like highlight the rows that you're interested in and you like hover over it, it will sum it for you. So if that's like a really crude way to do it for now, since we don't have like the totals by like each label name rolled up.
But could you show us how to do, or what are you talking about? Can you show it on the screen?
Sure. So let me go to like a non-highlighted row. So like for example, for average paid amount, if you just like select all 5 of these and you hover, it'll sum it for you. So the
Oh,
sum is so yeah. Wait, did it? I have no idea.
no, that
Never
doesn't look,
mind. Sometimes it works when I do it.
yeah, it does look like an average.
You do the total, yeah, let's see if it's.
So what do? You click on it and then do select and then down and click on the
No,
bar.
that's just the one cell that you're hovering over.
Oh, never mind.
Oh, okay.
But I notice sometimes it does it, but yeah, I guess since I'm presenting, it's not going to do it. So.
It's always the way it works. Okay.
So I guess like we should decide if we think that the level that we've done this ranking at is not the best level, then we potentially want to go back and aggregate to a higher level, and what should that be? I definitely agree that it's I'm of two minds because I think the level that we're going to be doing the affordability review at, which would say whatever, if that's all the NBRLs or all the everything within one generic name, that's going to be doing with the level that we're doing the affordability review at. It would make sense to rank all of the drugs at that level. On the other hand, this is certainly easier, and then maybe it gives us a sort of a cruder sense of how the ranking falls, and then we can choose the drugs that we see, and especially if there's multiple rows for one drug. I don't know. What do y'all think?
Well, I actually think that we can pick it from this because of the fact that you can pull it out and see how many times it's on the list, and get an idea of what the total
Yeah.
cost is.
The concern would be, what if the drugs what if on this list there was one generic name that filled rows 26 through 50 that we're not seeing right now, but if we aggregated them, it would actually be number like 1 or 2 or something like that, and we're missing it because it's not aggregated.
Yeah, but these are based again on like these data measures. So if it's not already on the list, then it's probably like, for example, not a lot of people using it, or not a lot paid for it. So
Yeah, I was gonna say if it didn't make it on the list as is, the chances of multiple much smaller things aggregating to something, you know, is slim.
I agree. The example I made up is obviously extreme. I was just trying to sort of illustrate the point of like what we could be missing. Yeah.
Well, I guess I'd also say, remember, this is the first time, and we'll probably, want to make adjustments as after we have done our first round and figure out whether there's things that would make it go smoother or what, that type of thing too.
Well, yeah, and for example, the indications, that's something that's on our list of for the next go around of the dashboard to include that. But just timing wise, being able to put that in and make it all work and not, distort everything else in terms of how things display or fit, just didn't work this go around. But yeah, I think we have with the lists, kind of like Eileen was saying, I think enough that we can.
I agree. Wasn't and Is Ryan here today? I feel like Ryan had some like when we were defining this level of analysis, Ryan had some reason why it was something within the eligibility criteria that we decided on this level. I can't. Is Ryan here?
Yes,
Uh,
that's a good point.
yeah.
So when we were building out the list, we were looking at NDCs because we were looking at that cost threshold. And when we went back and had to revise that list, we did run into some of those issues. So that's why the dashboard is at this, individual drug product level. From the discussion that you were having today, it sounds like you really want it at that drug ingredient level because, as Hung had mentioned, you could do it at that generic name. So I think what we can look at is having it at this individual drug product level, right there at the top, it says the 25 prescription drug products, and also try to get, the top 25, drug ingredients where we can get all of the Intercepts, all of the adalimumabs, all of the others, um, and have you be able to look at it at both ways. So that way you can see if you do have a lot of different rows of the same drug that are taking up lower positions, but in aggregate are higher, and how that compares to some of these other higher drug products.
Thanks. That's helpful. Yeah, and that's I think that's what basically what I was trying to remember. So
Doug, you said you had some other,
yeah, I mean, just kind of like generally about the dashboard. When so this is gonna be like public on the website, right?
right?
So I think that like somewhere on the home screen, it should say like what is the point of the dashboard, and also and specifically within the flow of what the PDAB is doing. Like so it says this is the 294 prescription drug products identified as eligible for affordability review. And so like we needed to I think that it would be important for us, we have that like triangle in our slide decks that show like where the eligibility when we decide on eligibility and then we decide on affordability review, things like that. Having some information about sort of how this falls into that process, I think would be very helpful for the public because they're not going to know what the eligibility means or affordability review means and things like that. So yeah, that was one point of feedback. I don't know, and then I have another one, but I don't know if anyone has any comments on that.
No, I think that's a good idea in terms of just, we can maybe do some work on our webpage. So just on the webpage itself, maybe it explains the dashboard and again, kind of where it is in that step of, as we're moving through this process. So yeah, we can work on some public facing tweaks. Yeah, just to make sure it's clear because yeah, we know what we're talking about, but if random Mike from Spokane walks in here, he's gonna not know exactly what this is. So
Yeah, thanks. And then the other thing was on the prioritized list, or basically the last two tabs on the right. I like that you can filter by specialty, but I also like I would want to be able to see the list without that filter applied. So basically having both Y and N as an option. Does that make sense?
So the top 25, regardless of specialty or not.
Yeah. Just so you can see what that ranking is if you don't apply any specialty filter.
well, and Kelly, correct me if I'm wrong, but I thought the top 25 list was originally just the specialty, pretty much, and then we added the second one just to get a wider, hopefully, usage. So I think that the original 25 list is.
I think you're right. I remember that too. Yeah, so my thought was just that, so for instance, let's say that I want to be able to look by drug, and I'm looking at this, so I filter by label name, and I'm scrolling in there. I have to then go and alter my filter by specialty selection in order to see a different set of drugs. And so you never get to see the full list of drugs unless you play with these different filters. And so like that's why I think it'd be helpful just to have like the no filter option on specialty.
So are you saying like rank and weight all the drugs regardless of specialty or not? Or are you saying you want to see specialty and non-specialty, like the top 25 for each, all in the same list?
Um, let's
I don't
see.
know if what I
So
asked just made sense or
I
not.
think last option,
yeah, so basically it'll give you like the list of 50.
yeah.
Okay, yeah, I'll have to think about how to do that because like I put in this rank column here just to like show like the top 25 in order. So if I show it all, then I don't know how this rank is gonna like this rank column is gonna work. So yeah, I'll have to think about that.
Okay, yeah, I mean that was just like my thought was like it's helpful to see all of the like sort of if we have this ranking system that we've applied using all these data, I think it's helpful to see sort of everything that we've identified at the top of this list all together. And that's why I was thinking like, I want to be able to have the no filter option. But if I'm the only one that thought that, then maybe that's just kind of a weird thing to look at. But yeah, I don't know. Anyone else have thoughts on that?
I think you.
I concur. Oh, I concur with you, Doug. I mean, it's gonna be dominated by specialty drugs just because of the cost.
Right.
But that's still helpful to
and-
see.
Yeah, and so I think deciding on what to review, I mean, yeah, there's a criteria, but do we look at something that affects the mass, which are usually the non-specialty drugs?
Yeah, so maybe all the non-specialties are ranked 26 through 50, but then you can see as you go down that list of the specialties and you get to the non-specialties, you see how many more users there are. I feel like that would be, informative to our decisions.
Right, but the rank is by weighted rank, not by like
Yeah. Okay, so the weighted rank is within that is determined within specialties and then within non-specialties.
Yeah. So I was asking if you wanted like an overall list that was just a weighted rank for like just weighted rank by like not separating it out and just calculating the weighted rank and having the overall top 25 like we originally had.
Right. Yeah, and I remember that. And I appreciate that you did that and then went to this. And I get, like I said, I do think this is very good the way it is. So then if we had a weighted rank overall without that filter, it would essentially it wouldn't 26 through 50 wouldn't be non-specialty. They'd probably all be specialty too, right? Yeah, Hung is nodding, yeah.
Likely just because if Embrel is listed 5 times, you're gonna get 5 Embrels on there. That takes up 5 spaces.
Right.
Okay. So essentially the only way that we could sort of have one list would be to do the separate weighted rankings and then combine them, basically append the non-specialty list to the specialty list. And that would and then that wouldn't even reflect the true ranking. Yeah, and that could be misleading. So I guess it's fine the way it is. Just trying to think of a way to see them all together.
Yeah, and if you do the overall list, you're not going to see any new drugs. They're just going to be a combination of drugs on both lists, like Hun said. So
Okay.
you're going to see new information.
All right, that's fine then. Forget it. Forget this idea. Yeah.
Hey, Kelly, can this be filtered by therapeutic class?
No, but would you be interested in having that filter?
Well, so yeah, the reason I say that is, just reading back some of the comments, right, from pharma and then from each coalition. I think, when you pick one, it affects the others in the same class. And this could be formulary choices, it could be provider selection. And so when we do a review, we have to think about, is there other options of how we're viewing? Do we review the whole class? So that way it decreases the downstream effect on others, right? Pharma has a good point that, you're picking one, then that's the one that's getting looked at. How about all the rest, right, in the same class? Now, granted, I was thinking disease state, but then a drug can be used in many, right? Um, Many uses for it, as someone commented. So is it the class we look at? I mean, I'm just thinking, trying to think differently, taking account the comments that we're seeing.
Yeah, I could add in a filter for therapeutic class.
Great. Any other questions on the dashboard? Okay. Well, we can continue refining this down, and there's a 100 different ways to slice and dice all of this. Each with its pros and cons, but we'll keep trying to add more features just to help us see and organize things a little bit better as we go. But if there's no questions on the dashboard functionality, then we can move on to the next topic, which is more discussing the actual content of the dashboard.
And the advisory group members are going to tell us how they came up with their list also.
Yeah, so I think what we're going to do is Simon has a small slide kind of showing some of the cross between how the advisory group members selected things. And you can kind of go through that real quick, and then we'll open it up if the advisory group members want to chat about their selections and why they did so, and if the board members have specific questions for them. And then we can kind of move on from there.
Okay. So,
Taking a second to load up.
Okay. All right, we'll take a breath. Beginning to think our technology in this room isn't the greatest. I don't understand.
I haven't pulled up, but it's just giving like an error message, taking a second, so just bear with me.
Want to take a quick break while we figure out our technical stuff, Simon, do you think?
Sure. Yeah.
Okay,
5?
5 minutes. We'll be
Okay.
back in 5 minutes.
Okay.
While we work to get our technical
Okay.
problems arranged.
Okay, sounds good. So 5 minutes, sorry for the delay, just trying to get computers to work, and then we'll be back. Put it on, turn off the video just for a second.
Okay, we rebooted, so things are working now.
Okay,
All right, so, do you want, who wants to talk?
yeah, sure. So we're back. We got our computer issues sorted out. So now I think we can go through the advisory group recommendation. Simon, I'll let you just kind of walk through this real quick, and then we can open up the floor to our advisory group members if they have thoughts and comments, and then the board members if they have questions.
So each of the advisory group members was asked to submit their top 5 drugs that they would recommend for review. And as we just discussed, you have in the broader list the drugs with the doses, but what I did was I just simplified if 2 members said Enbrel, whatever the dose, I just counted it as 2 votes for Enbrel. And then what we've done here is just put together a simplified list of what are the drugs that multiple advisory group members suggested. And so if at least 2 suggested a drug, we put it on this list. And then we went and just for information purposes, sought to see if ICER had done an analysis on any of those drugs. And it turns out for these ones, there are analyses available online for all of them.
How many advisory group members are there?
5 total and 4 submitted recommendations, because 1 is a conflict of interest.
I think, okay, just checking to see how this plays out. All right, well, we have a couple of them, I don't even know who everybody is, but I know Ronnie. And, yep. So does anybody on the advisory committee want to tell us why you chose what you did, or what your processes were? Go ahead, Ronnie.
I can start. So I chose drugs that were indicated for different purposes, uh, so that we just knowing that drug prices are related to a disease state. So looking at it from that perspective, I tried to divide my group up. Most of them were for rheumatoid arthritis, but they also have combinations of conditions that are addressed. So I used that as one factor. The other factor was looking at the ICER price increases over the past few years, and that helped me choose the 5 drugs that I chose. So it was a combination of past price increases, uh, which we don't have records of because we're just starting, and the conditions, the disease state that they're indicated for, because I think there are economic factors that determine prices within the disease state. So by choosing one from 3 different disease or conditions that are on our top 15 list, I thought that would give us a model to follow for future evaluations. And I did look, I found the, the, the data from the dashboard very useful to look at the number of patients and using a drug. And so that were my parameters.
And Tim Lynch.
Yeah, my selection criteria was really based upon, I thought the staff, the ranking provided by staff was very objective, and they used a standardized process, which I really appreciated. I also looked at the number of patients that were impacted by the drugs. I felt that I really wanted to capture more patients that would be impacted by a focus effort. I also did not want to duplicate drugs that have a different dose depending on the indication. And so I tried to take that into consideration. And then also the therapeutic class, what they were used for, and the patients that would be impacted by that. That was the criteria I used.
And Laura Berry.
Well, let me first start off by saying I wanted to discuss some of the issues that I was having. I felt that I looked at the list and I saw, for example, Enbrel showed up 5 times on the list, depending on different delivery devices. And I didn't know, because I don't have a medical background, what the different delivery devices would be used for. For example, one that I was able to find, there was one particular delivery device that was the only one that's approved for children. So we wouldn't want to rule out that particular, and unfortunately, I can't find it in my notes that I took earlier, but I think it might have been Humira, one of the delivery devices approved for children. That would have to stay on the list if that's the only thing that's approved. But for example, Enbrel, I had trouble because I didn't know if you change a delivery device, if it's going to change the patient compliance. And if you change the patient compliance, if you're going to end up with more people, for example, in a crisis, and that of course would increase your whole cost. That would remove your purpose for saving money on these drugs. So I felt that I needed more assistance from a medical standpoint in determining which of these drugs would be cost efficient and for which purpose. Like Enbrel could be treated for rheumatoid arthritis, or it could be ulcerative colitis. And one of these drugs may be better for one particular item, but or more cost effective for treating colitis, but less cost effective for rheumatoid arthritis. So I just wanted to put that out there, that was a significant question in my mind on how to go about resolving that. I also know that some of the board members had chosen based on out-of-pocket expenses, but I couldn't find anything in the spreadsheet that listed the patient assistance programs that are offered by most manufacturers. And although they are stated as offered to people to help with low income, they're really provided to everyone. I had a child on a very expensive drug program for many years of his life and was provided a drug assistance program, but no one ever asked me to provide any financial information. As a matter of fact, it was just simply assumed that I would want it. And of course, I took it because it was a very, very expensive drug. But I didn't have to provide any information. So whatever the drug said it cost per month, I paid a small fraction of that amount. So if that's a consideration for the board on the patient out-of-pocket expense, I think that needs to be researched a bit more. That being said, I made the choices based on the information that I did have. And I looked at the National Institute of Health recommendation that said that Humira treats autoimmune diseases at a more cost-effective basis than Enbrel. So I just made that choice there. And then also based on the same sort of information, I recommended that Taltz be reviewed for cost savings by simply the delivery devices that substituting a multi-pack is more cost effective than the single pack.
Okay,
Anyone have any questions about what I've volunteered?
Daria, you want to tell us
Okay,
what?
thank you.
Hi, thank you, board members, for taking the input of the advisory committee, Daria McGrew on behalf of Pharma. So as was mentioned by Mike, we did not submit any recommendations for specific drugs as I'm here to represent the industry at large. And I would be remiss if I didn't caveat that we do have legal concerns with the underlying statute and some of the implementation so far. Getting that out of the way, I do want to speak to, there was some discussion at the advisory group and earlier with council about the random whether it's arbitrary or not. And I think that this exercise is an example of that. The board has gone to great length so far to calculate, do a lot of back-end calculations at the staff level on eligible drugs, to create a methodology for quantifying everything that can be quantified, to do the ranking exercise to get to your top 25 drugs, to create the dashboard, to do everything in quite a methodical and reasoned way. And then after getting to your top 25 list, by taking input from various board members based on whatever factors are important to that board member, while they might be important factors to that board member, if drugs are chosen for review based on random factors, this is where we get to the observation that it is becoming arbitrary. What is to say that a drug wouldn't be chosen by someone because they don't like the packaging or the advertisement that that they see on TV, and that is not a metric of affordability. So that's why we have cautioned that this final step in asking for input from board members, selecting drugs based on that input for the final step is not the best idea. Thanks.
So Daria, are you saying that you think we should just take the top, however many we decide to do, by the weighted rank?
I think that the board should have discussions about choosing based on a metric, whether that's X number or whether that is, however it's filtered, it should be based on a quantifiable metric and be X number of drugs based on that metric decided by the board. Yeah.
Ronnie, did you have something else to add? Or is your hand just still up?
No, but I don't really understand what Daria is saying that we are using metrics. Is that not your perspective? That we're making some kind of arbitrary decisions? Is that your criticism of the process?
Yes, that up until this point, the selection up to the top 25 has been quantifiable use of metrics. And then, the board is required to solicit input from advisory committee, and that is appreciated. Technical input or metrics that factors that are important to advisory committee members, to board members. But if considering that the next step is to choose X number of drugs for affordability review, if those X number of drugs are chosen at random from the top 25 list, then you've undermined all of the methodology and quantifiable work that's been done up until that point.
Thank you. And I think
Jim?
Jim has his hand up too.
Thanks, I appreciate that. And I don't want to wade into the legal aspects of something that I'm, not prepared to go into. But I think it's not at all unusual for state policymaking bodies to have official advisory entities making qualitative input for policymaking decisions. That's very common. And so I think, the PDAB's really doing its due diligence to incorporate multiple factors with some precision into this decision-making process. I would kind of echo what others have said about the influences on the decisions that we made individually as advisory group members. Another one that I haven't heard discussed yet is how other states are including drugs for review by their PDABs. I thought that was an important consideration for us to look at how other states are doing analysis as well. So I'll just add that as an additional factor for my decision.
Great. And thank you very much for that feedback. I really appreciate the time that the advisory group members put into their recommendations. We forwarded all of your specific recommendations and reasonings to the board members to take a look at, and appreciate you taking the time to talk about them a little bit more here in depth. I think the advisory group, it's outlined in the legislation as a requirement. We're supposed to get that feedback and input, and I think everyone coming from your different backgrounds. Laura, for example, I appreciate your thoughts. And just kind of specific lived experiences, which are reasons why this work is important to everybody, and which give us that experience and that desire to participate. So I think that's very important. And then just with the drug list itself here, we have Daria. I appreciate bringing up that we've worked hard to do these methodologies and create this list. At the same time, I think using all of this information that we've worked to create is part of how we then come to a reasoned decision, kind of like Michael was talking about in terms of, it isn't just Greg taking a dart and chucking it at our list of 25, and whichever one it happens to land on, that's what we go for. It's using all of the information as well as the input from our advisory group, as we're required to do. And I think, as Jim rightly pointed out, which is a very standard practice across government, to then combine this information to make an informed decision and a reasoned decision using the data at hand. So I appreciate that very much. Board members, do you have any other specific questions for the advisory group members and some of their thoughts or comments on their selections?
Well, I was just looking at of the record, the drugs that they recommended, they're all in the specialty or the non-specialty in the top 5, I think. So I guess I guess this is for Daria. From what you said is that you're thinking, I guess if we would do how you describe it, you wouldn't have the differentiation between non-specialty and specialty?
That's a decision for the board. The board just voted on the policy as laid out that did differentiate specialty and non-specialty drugs. I think that I'm not saying that that's an improper or a proper way to do it, but that decisions should be made by the board using quantifiable, reasoned metrics.
Hi, this is Ryan. I just kind of wanted to reiterate that the reason that we did split up the list between, specialty and traditional drugs was that was a request, from the board, because when we had originally presented the list in November, it was dominated by the specialty drugs, and they wanted more information to see how non-specialty drugs are, given that they do impact different disease states and therefore, different populations around the state. So I think, one of the reasons for having these two lists, was to be able to better understand how different populations are affected by these drugs.
Any other questions from the board to our advisory group members? No? Okay. Well, then I think that can kind of take us into the next phase of our discussion, which is, I know we talked a little bit about this last time in terms of the number of drugs that we were thinking about, and then which of those drugs, based on the board member review and the advisory group input. So we can kind of go dig into that a little bit more. Again, my intent today isn't to say these are the 3 that we're for sure going to choose, but rather let's come up with a short list here of things that we can ponder about until our March meeting. And then, if we need a little bit of additional tweaking to our dashboard or some additional information, we can gather that and kind of go from there.
Well, I guess I have a question about where we're at in some ways. I know that we have this little budget problem and that contracts are not being, you can't move forward with contracts. And so how is that going to affect us? I mean,
So right now, in terms of budget, I know everyone's kind of getting their belts tightened a little bit over the next 4 or so years.
That kind of plays into how many we think we could actually do.
Yeah, and so I can't tell you all the details of exactly how this will work out, because I think there's still quite a bit of uncertainty around budget and staffing.
Yes,
and all
there will
that.
be until at least April.
Yeah. So yeah, until April, I don't know that I have definitive answers. But that being said, knowing that there is a level of uncertainty and that resources have a decent chance of being constrained in a number of ways, I think a more modest approach to start with until there is a little more certainty, would probably be preferable, from a staffing point of view.
So we might want to like come up with the top 5 and then say you go put them in order so that if you don't have the resources to do all of it, that
Yeah.
you cut off.
Yeah, I would say, yeah, kind of have our short list in March. We can decide for sure. Hopefully, maybe there'll be a little bit better, clearer picture of what we can and can't do during that meeting. And then, yeah, we can start out and do 1 or 2 drugs at a time, see how that goes. And if we aren't able to get to certain drugs, we can either put that on the docket for our follow-up year, or maybe the next go around decide, hey, there's something else that's more enticing that we want to chase right now.
Okay.
So, and that's just kind of me thinking out loud, but again, leave it up to the board's discretion on what you all want to try.
Okay, Bill. When's cutoff?
Cut off.
Oh, it's so long. Now it's
Right.
like later February, yeah,
Well,
first like.
First
Oh.
one's February 21st.
Really? That seems early to me. Okay, just so I was trying to figure out for March.
Yeah.
That's the committee cutoff. So then the floor cutoff isn't till, it's gotta be March.
It's kind of like around the 20th.
Yeah, that's what I would think. So. And fiscal cutoff, you know that?
It's a week after policy, so it's like the.
Okay.
Yeah.
Yeah, I'm trying to like figure out where we'll be at, whether you'll actually know anything on.
Yeah,
like-
well, yeah, and I mean, again, we've been, this is all new, so all of this is kind of a figure it out as we go. So we'll keep figuring one way or the other. Just sometimes it might take a little longer, depending on circumstances.
So at this point, we need to think about how we're gonna cut the list down, or
Yeah.
what list, okay? All right, guys. Comments?
Doug, do you have a handful that you feel passionate about? Greg, we can.
No passion, just numbers.
Oh, that's right.
But well, I mean, I think this goes back to the first thing we talked about today that Greg brought up. I want to be able to aggregate this list by generic name, both lists, the specialty and the non-specialty list. Because Enbrel looks like it's probably number 1, but I want to add up whatever the 5 Enbrels on this top 25 are, and I also want to add up the however many Xeljanz as there are on the non-specialty list and see how that compares. It's not quite apples to apples yet, because this is not the rows of these lists are not the level that we're doing the affordability review at.
Yeah, I totally agree. I kind of want to see top 5 or even like top 2 or 3 probably to start, and see how stark those numbers are compared to the rest of them.
Yeah.
And probably just go by numbers. I mean,
I'm honestly, I'm just trying to copy and paste into Excel right now, and I can't do it. So
We do have that Excel list that we sent out with the indications, and you can filter that. Well,
but do we always
I also want to say, if you're trying to sum, it might not always be accurate, because sometimes there could be people double counted that probably use maybe they went between the same brand name but different doses or something like that. So
you're saying that an annual estimate of, let's say we have the 10 milligram row and the 20 milligram row, the same dollar went into both those rows?
And I'm saying if you're trying to sum it yourself, then we might double count people because they could have been counted if they had a claim for like the 10 milligrams and then counted if they had a claim for the 20 milligrams. But if we did it on our end, we would only probably count them once if we're like collapsing the ingredient name together.
Okay. That probably sounds like, that sounds to me like what we need to do, right? I mean, that's, yeah, you're right. So I just pulled up the Excel sheet that you sent, and yeah, we do have some numbers here, but Kelly's warning us that that would be a bad idea.
Well, but that's, Kelly, is it just the people, the number of people? It's not the money.
Yeah, the number of people, but that's also used in some of the other data measures. So yeah, I don't want to mess that up.
The average out-of-pocket cost can be determined by the number of users.
But I mean, ballpark,
Yeah.
you know, for general purposes, I mean, I don't think we should be that far off, but yeah, we can work on some summing. So, I mean, maybe do we want to have, I mean, just kind of looking at it, we can talk about our, again, maybe our top 6 to 8. We can, over the next month, come back with these summed features to either confirm or deny maybe assumptions that we have, and then make that final decision in March.
So our goal is to basically get our list done in March.
Yeah, to choose the drugs that we want.
I'm just trying to like play the.
Yeah.
I can tell you that I live in this world day to day, and it's consistent, the list. It's exactly what I thought it would be. And obviously the data is showing that. So I don't think it would be that difficult to find to get that 6 to 8.
Okay, so Hung, what do you think the 6 to 8 is?
Amwell, Humira, Cimzia. What's on there? What's on there? I mean,
Cerencia.
it's
You want Kelly to pull up the list for the screen and we can look at it on the dashboard?
yeah, the most of it will be the anti-inflammatory, because you know if you look at oncology, there won't be that many people on it. There won't be as if you're looking at total cost. Enbrel Humira, it's used for any type of colitis or inflammation. They're prescribed left and right.
And my thought is that, like I certainly trust Hung's judgment. Like he knows this, he's in it, and I would guess that his rank is probably going to end up being what our rank is after we aggregate.
Yep.
It. However, in this public meeting where this is all on the record, if we go and say that we're judging off of what Hung says he thinks is the top 5, like that's not gonna, like I feel like we're gonna get sued. That's not gonna stand up. If we have the same top 5 that are ranked according to our objective metrics, and then that's how we arrive at that top 5, then I think we're in good shape. And so that's why like I'm reluctant to kind of like name names until we have the level that we're going to be doing the analysis at.
I concur, Doug. What I'm saying is the top 15 or 20, any of it can be in the top 6 to 8. And you won't get an argument from me based on the data. That's all. Right. And so if Mike was asking what would be my guess, well, those are the top 3. And I'm sure it's up there. We saw it. So that's all. Dolly has a good point. We can't be arbitrary picking it because I like one brand over another. I have no allegiance to any of this.
Okay. Greg? Eileen, thoughts?
Okay, go ahead.
I feel the same way. I think, yeah, we need to collapse the generics within the top 25s and then sort them, and then that would be my preference to just go top to bottom.
Well, I'm trying to look at, when you look at the non-specialty and the specialty, I agree with Doug that it's a little hard not to have them put together. That's the one thing so I'm kind of going back and forth between the two to see where the non-specialty would fit in. I mean, the specialty are usually more expensive, but but depending on, actually the first one I think would extend specialty. It's also very, I'm in the non-specialty. I think that extandy, is that how you pronounce that one? Would probably fit the rank. Its weighted rank is 2.46. So that would, if we were just looking at the numbers on the rank, I think it's in the top 5 too. So
Those weighted ranks are calculated separately for specialty and for non-specialty. So that wouldn't necessarily merge in. But I totally agree with your point though. So actually I have both lists open next to each other right now, and I'm trying to
yeah, that's
see how they fall.
I can't do that on my iPad.
Right,
So.
yeah, no, I understand. Yeah.
Okay, so long story short, then we want to be able to sum each of the, sum all the Embryls and the Humiras and everything together to see how they fall within that top 25, correct? And then from there, see how they rank, and then also join the 225 lists together and kind of see how things compare, just as basically a top 50 list, but with each of the drugs summed together to make a smaller group, correct?
Yeah, and so it's making that, like Ryan talked about, the rather than the drug product level, it's the drug ingredient level.
Okay.
Marina?
Yes, moving forward to the affordability review, what I'm hearing from the board member is that the grouping that you want to see is the group that we are going to conduct an affordability review, and how you're going to make the final decision on the affordability and the payment limit. So there was a discussion came up in the past about how to group some of the NDCs. Is it just the brand name versus generic name? How about different formulations, especially steroids, that kind of stuff? And let's say some generic drug have different brand name, even though it's the same drug ingredient for different indications. So I'm just wondering, I think it's good to hear your thoughts, how exactly you wanna group some of the NDCs. That way, when we move forward to the affordability review, we don't need to regroup some of the drugs. So that was my question.
I guess do we have, I'm looking at our 2 top 25 lists. Are there any, I'm looking at the generic names and they all, and I'm just trying to see, are there any that if we tried to combine, we would see if we're combining by generic name, do we end up seeing a conflict in the brand name within one of those groups?
Yeah, and that's, I think, another question too. Are we doing a regrouping for the whole drug list or just the top 25?
My thought was just the top 25. And again, that comes back to the definition of eligibility that we used, which is at this NDC level.
So
that should be probably relatively easy, Kelly, right?
I guess some of the strengths or formulations not on the top 25 may be grouped if it's not in the current top 25. It's a bit complicated.
So the question is, would we take So we have 296, is that right? 296 eligible drugs?
194.
Okay. Do we go back to the 294, aggregate, and then do this sorting? Or do we just take these top 25 and aggregate and sort?
Seems like just the 25, because we already know where they have fallen, and
I think
we're
Marina's
not
point
looking
about
for
it.
a lot more drugs. Let's just put it that way. We're not going to be able to do all the
Yeah.
25.
But the question is though, like, so what if, when we aggregate the Enbrels, what if there's another Enbrel that's ranked 27th? Do the costs for the 27th one get added to our list here? I would
Oh, I see what you're saying.
I think yes, but I'm not sure. Yeah.
I would vote for yes on that as well.
Yeah.
That's gonna be the total impact of our final actions.
Yeah.
We need to know that.
And so I think again, going back to the whole reason we have it at the NDC level was because that's how we made our eligible drug list, and that's from the statute. And so that's still fine to have that as how we got to the 294. But then as we go through this prioritization process, I think it makes sense to move the level to the level at which the affordability review occurs. And so that's why I think switching to generic name makes sense. I'm curious to hear what a pharmacist would say about combining across formulation. Like whatever, a cartridge and a syringe. Are we gonna aggregate those in together even?
Hey, Ryan, let's get your thoughts.
Yeah, I would say that it should be fair because the device delivery system may be a provider preference or a patient preference. So if you're looking at whether you would want to combine a syringe and a, auto injector, I think that they would typically be considered the same drug. It's just that some patients, may prefer a insulin pen. Others who grew up and were trained on a syringe and vial may be comfortable continuing on a syringe and vial. So again, it would be both an appropriate therapeutic option for them. It just may be a preference.
Thanks, that's helpful.
Ronnie, you got a thought?
And I think to answer your question, Doug, different doses may actually be indicated for different disease states. But to me, the question we're asking ourselves right now is, where do we get started? I'm hearing a lot of conversation about the final solution. I think we're looking now, correct me if I'm wrong, but we're looking now at getting started and trying to provide some key medicines, key drugs, and certainly the question about aggregating, I don't think is a question. I think that's the only way to do it, and it's certainly what other prescription drug affordability boards have done, what Medicare negotiating prices group has done. So I think aggregating the drugs is important. I think what it seems to me the decision right now is how do we get started on these groups? I don't think we need to be concerned about leaving something out in the long run. I think this is a marathon, not a sprint. Thanks.
I think you have that right.
Any other thoughts from the board members on next steps then?
Well, I guess I'm just wondering, are we in agreement on this, and do Kelly and Marina understand what we're thinking?
Kelly and Marina, do you understand what they're thinking?
And are you going to be able to do it?
Yeah.
Mike and Michael, I don't know, like, is this supposed to be in the methodology policy somehow? Like, how exactly to, like, group some NDCs or identifying the group of medications for going towards the affordability review?
Yeah, we'll probably have to do some tweaking there on that. Kelly and Ryan, in terms of grouping these together to create basically a summed list of the top drugs, does that sound reasonable?
I think I have an idea on how we can group these drug products together to give a summary level, kind of ingredient level um, overview.
Okay. So then we can do that here and then come back to the next board meeting in March, basically with our summed list, which, you know, given the repetitive nature of some of the drugs, should hopefully be decently short. And then we can kind of go from there. And it sounds like the board members have been looking at the dashboard, kind of have an idea of what they expect in terms of the top drugs to be. But we can just make sure our data confirms what our current dashboard is indicating. We can kind of go from there.
Yeah, and the thing I would add is just that, you know, that the dashboard as it is great. And so like, you know, keep the product level list on here. It's good information. But I'm thinking about this as like another tab of the dashboard that we can then use to see it at the drug ingredient level rather than the drug product level.
Okay. Great.
That's good. You don't want them to redo the whole thing.
Just add more stuff.
More work. Just a little more work, right?
Yeah.
With full employment. Okay, so that wraps that
Yeah,
one up.
I think that kind of wraps it up. Ryan, any other thoughts of things we need to talk about?
Well, I thought the discussion today was very good in helping us understand how you want the data to be presented and what you are looking for in terms of evaluating these different drug products. So I think I have everything we would need in order to update this list for the next meeting.
Great.
Okay, then public comment. Do we have anybody signed up for public comment?
I see, I think it's former Director Bertier. Are you a member of the
Not yet.
public,
She's got
or
a
are you
couple hours
member of the Healthcare Authority?
Yeah, gosh, till
Got
12 noon.
Got to
Okay.
do.
All right.
Actually, can I sign up for public comments? Take executive privilege. I actually just wanted to step down. I'm Sue Birch. I'm the director of the Healthcare Authority. I want to thank this board. This is hard work. This is work that is coming before its time. While there are a few other states that have this work in motion, you all continue to pioneer forward. And so I think we're going to see so much more, especially with this new federal administration coming down about drug prices. Really important work. I just want to thank you guys. And who knows, maybe I'll be working from the outside to kind of accelerate your pace. And that's all. Thank you. Oh, and I see a hand up. Sorry.
Thank you. Wanted to add on for the public comment, not just about the advisory committee discussion. So I wanted to add on a couple other things. Daria McGrew on behalf of Pharma, for the record. Just want to say again, I do appreciate the board hearing input from the advisory committee. It is absolutely critical that the board hear from consumers and providers, and appreciate taking technical input from industry as well. So I want to make that clear. I wasn't saying that the board shouldn't hear that input, but that ultimately board decisions need to be based on reasoned metrics. I want to, take the opportunity to remind board members, there was some discussion about cost to the healthcare system. So just, our standard reminder that when a lot of the metrics that go into your list, APCD data, are based on WAC data, are based on list price and not net price. So, of course, you're not looking at affordability to the system because you're not looking at what payers have actually paid. So that should always be in the back of your mind and hopefully publicly stated in documents like the dashboard. I think we will go back, and I'll take the discussion today and the dashboard now that it's public, go back to our subject matter experts, evaluate it, and submit a letter after the meeting with some more technical comments on that. I'll have to review comments earlier in the process on whether or not to roll up drugs at first blush, I have concerns with some of the discussion of rolling up drugs based on different delivery devices that is concerning to us because, often a new delivery device offers a big advancement in patient benefit. I think it was mentioned that it might be better for the patient, and therefore adds a lot of value. So when you're thinking about value to the healthcare system, the improvements in delivery, those two drugs are not the same. Those two drugs should be considered differently because a new delivery device often is a major advancement, or it could be a drug that is taken hourly, becomes a drug that is taken daily, becomes a drug that is taken weekly, while they all have the same drug product. Those changes in drug development are major advancements and have a major impact on value in the healthcare system. So we will submit a letter in a couple of weeks regarding today's discussion and the dashboard. Thank you.
Anybody else that's signed up there? Simon? No? No? Okay, I guess that wraps the meeting up then. Thank you, everybody. And you get to think for the next 2 months about all of this. I'm sure we'll be hearing from Mike and Simon.
Yeah, we'll try and get these revised pieces out to the board sooner rather than later. So hopefully, we have time to ponder it, and kind of come to the next meeting, hopefully with some pretty set ideas of how we want to move forward. So,
Okay.
okay.
Looks like there's 2 things in the Q&A. I don't know if
I think that was from earlier.
that old stuff.
Yeah, it's when they
Okay,
couldn't hear us.
just making sure.
Yep. Okay,
Thank you.
meeting adjourned.
Thanks, everyone. Bye.